Hey guys, what's going on? Tony here. So I got a whole bunch of questions that came in last night from a therapist who has who's been contracted with Medicare, and now they're looking to start their private practice. And so these are great questions. These are the same questions that other clinicians out there have had, and I figured, you know what, the easiest way to answer these questions is to do it on video so that you can all benefit from my answers. And what we're going to do is I'm going to share my screen. I'm going to show you the questions. I copied and pasted them onto this document, and we're just going to go through them. So question number 1. Do I need a physician's referral to treat, or just a physician's signature on my evaluations? Now, to quote one of my dear friends, Nancy Beckley, you have to ask the right question to get the right answer. And in most cases, you probably need to know the answer already before you even ask the question. So the problem with this question is there's kind of this I'm going to say a misunderstanding in the terminology between what's an evaluation, what's a plan of care, what is the certification that is required, and then the understanding between what the State Practice Act may dictate versus what the payer requires, because those are two separate things. You might be able to treat a patient through direct access, but that doesn't mean that the payer is going to reimburse you for it. So you have to understand both worlds. The place you find this information is the Medicare Benefit Policy Manual. So this is under, now you got me guessing, under section 220.3, documentation requirements for therapy services. This is something you just have to read and read and read, reread it, know it like the back of your hand. But basically, when we're talking documentation requirements, we're not talking about the referral yet. Give me just a second on that. You may have an evaluation, and in the same document, it may include the plan of care. The plan of care is what must be signed by the physician or the person referring the patient to physical therapy, and that is the certification. There are certain components required within the plan of care, but if you look here, it may be 1 or 2 documents. I can tell you that in my facility, we use one document that is both an evaluation and plan of care, but that does not mean that the evaluation all has to be completed on a single session. So me as a therapist, I tend to believe I cannot adequately evaluate and fully comprehend the extent of a person's living situation, social history, past medical history, present history, everything that's been going on for this person in a 1-hour session. Even 1 hour one-on-one. I need to see this person a couple times. I need to really get to know this person, get past all the kind of insecurities and the stuff that gets in the way during that first interaction. So my evaluation truly probably lasts 2 or 3 sessions. But that being said, the plan of care is what needs to be certified, and that's what needs to be completed before treatment can begin. You don't need a signature on it before you begin treatment, but it does need to be in place. And so that's one of those documents where you could, in theory, separate it. So on the initial contact, that first visit, you start your evaluation process, you create your plan of care. You send that plan of care off to the referring provider. In the meantime, you initiate treatment and you continue to collect information to perform a really comprehensive, holistic clinical evaluation for this patient. So back to the original question at hand, the second part, you need a physician signature on your plan of care, which may or may not be the same as your evaluation. That's up to you. That's up to the way you run your business. If you get into, I'm going to back out here just a little bit, the Medicare Benefit Policy Manual, you can come in here, you can see what's required for an evaluation, progress note, treatment notes. It goes through pretty detailed information on all of these. You can also find what's required within your plan of care so that you know what is the minimum acceptable standard. Now, I will tell you that if you have a referral in hand, it's going to make supporting the need for physical therapy, occupational therapy, speech much easier, so that you have that as kind of backup to support medical necessity. So here is the information on certification for the therapy plan of care, PT/OT speech. This is where you can find the timelines, how long a certification could be made available, just all the information, and then what happens if you don't get the physician's signature, a delayed certification, how all of that works. That's all in here. So get in here and read this. Now, the original part one of the question, do I need a physician's referral? Based on your state practice act, you may or may not. Most states now, I think all states, have some form of direct access. So from the state perspective, you might be able to get away from requiring a physician referral. From the payer's perspective, I can tell you that while the referral isn't required, it is encouraged, it does help, and then you do need that signature on the certification. And I can tell you that if you submit a CMS 1500, whether it be paper or electronic, it will be denied if you don't have a physician in box number 17 and the physician's MPI. So that's one of those things that the physician has to be involved, the referring provider has to be involved, but you do not need the referral to start and perform the evaluation, but you do need that signed certification in order to continue care. So all of your information is listed right in there, CMS Chapter 15, the Medicare Benefit Policy Manual. Let's take a look at the next question. How does a private practice typically go about getting all the med diagnosis? So I'm going to probably guess medical diagnosis and medications put on the eval. So the reality is, in private practice, we don't have near the access to medical information and the patient's medical record as somebody would in a hospital-based facility. We can't just pull them up on Epic and see what they're doing. The privacy laws are such that we don't have access. So you're kind of relying on the patient either bringing you a medication list, these are all the medications I'm taking, or trying to tell you what medications they're taking. But having that information, or some, when I document in my medical record, I'll typically say per patient report, patient is currently taking XYZ for these conditions. I don't typically list dosing or anything like that. I just need a general idea of what medications they're on and what the purpose of those medications is. Now, in terms of the diagnosis, so again, there may be some state variation within this, within your practice act. Some states are very clear that what you're allowed to do in terms of a diagnosis. If you are not allowed to diagnose this, and this is covered in the Medicare Benefit Policy Manual, so jump in there. I did a video on this already. You can use the diagnosis that comes on the referral if you get a referral. You can also create a treatment diagnosis, assuming your state allows this. So a common example might be a patient is coming, with past medical history of Parkinson's disease. They're having difficulty walking. They're having some chronic low back pain, some knee pain. There's some neurologic conditions that are going on here. I'm going to choose, to the best of my ability, based on my evaluation and the assessment and my findings, what is going to be my primary treatment diagnosis. If the patient, in a situation like that, it's probably going to be difficulty walking. It's probably going to be R262. Maybe secondary conditions might be right knee pain or M545, low back pain. I'll throw in a couple diagnoses if it is a complex case, but in most situations, I'm going to choose the primary functional limitation that I'm trying to address, and I'm going to choose the diagnosis code that most closely represents what I am doing. Now, use your judgment. I always say the beauty of being a business owner is you get to choose what's important to you, what's important to the patient, and the whole clinical experience. So from my perspective, if a patient comes to me with right knee pain, low back pain, and difficulty walking, right? What I do for the difficulty walking is probably going to be the same stuff I'm going to do for low back pain and for knee pain. So my primary treatment diagnosis is going to be difficulty walking, because from a functional perspective, from an impairment, limitation, disability perspective, that difficulty walking is the biggest problem this patient is facing. And by treating that, I'm also including the low back pain and the knee pain. I will probably list those as secondary and tertiary diagnoses on the claim. In terms of the diagnosis pointer, and this is all terminology I know you're probably not familiar with, but I've got videos on each of these. You know, I'll probably list A, B, and C as my main diagnoses. I did recently have a situation, classic example. I'm treating a patient for low back pain, M545, and then 2 weeks into treatment, they come with a referral for neck pain. So in that case, I do an evaluation on the neck. I continue treatment for the low back. I add that diagnosis onto the episode of care. And for that particular date of service, I added M542, neck pain. I created a diagnosis pointer that pointed for that line item just to the evaluation of the neck pain. But then everything else was for both diagnoses, the low back and the neck. And moving forward, it's for both diagnoses. So I have videos on that. I hope I didn't lose you on that, but basically in terms of where we're getting the diagnosis information, either it's coming directly from the referring provider, or you're determining what you're treating and what the treatment diagnosis is going to be. It's not always what the referring provider is sending you. But whatever you put on your plan of care, and the physician provider who's signing off and certifying that plan of care, now that's the new medical record. That trumps, supersedes, replaces what may have been written on the physician order. Okay, do I need a HIPAA compliant fax service? Absolutely. Absolutely. If you're using an electronic fax service, you need a BAA, you need that HIPAA compliance to be protected information. So that would definitely be something that you need to look into if you're just using kind of your traditional telephone line. Like we use a paper fax telephone line system, but I know a lot of people are using electronic faxes to send and receive. So do I even need to get credentialed with Medicare Advantage plans? And what specific plan requires? That's a big decision for you. So Medicare Advantage is Medicare Part C. I did do a video talking about Medicare Advantage, and I will say that while there's still a tremendous amount of confusion in the consumer's mind on, do I have Medicare, do I have Anthem or United, or it says Medicare Advantage, what does that mean? I'll tell you that from my perspective. Now this is just me, I'm not giving you advice, I'm sharing my experience. When we look at the Medicare Advantage plans, we basically look at them just like a commercial payer. While they do tend to follow Medicare guidelines, they don't always follow Medicare guidelines, and the contracts are a little bit different. Many of these plans have high copays, $40, $45, $50 copays. So if you weren't going to credential with normal commercial payers, I'd probably say that you wouldn't also credential with the Medicare Advantage plans, because they really are just like commercial health insurance from a practical standpoint. You're still going to be collecting copays. On some of them, you're going to be requesting authorizations. Some of them are doing, notes and medical record reviews. It's definitely a different world than traditional Medicare Part B. So I wouldn't necessarily rush out to credential with a bunch of Medicare Advantage plans. And I do believe that this takes a lot more kind of thought in terms of, do you have the infrastructure and the system to handle that? My guess is probably no, since you didn't choose to credential with normal commercial payers. But this is something that definitely need a little more investigation, a little deeper dive. So guys, that was my answer to these 4 questions. I am sure you guys have way more questions than this. I'm sure you guys, you know, when you first kind of face that Medicare mountain, it's intimidating. It really is. We all started in the same place. I'm telling you, 2002, I think it was, I was in your shoes. And worse, I didn't have access to the Facebook groups and the free resources that you guys have available today. I was out there by myself, just like so many in the profession. But we do like we do. We have a goal. We want to achieve that goal. We put on our big boy pants and face the music and do what we need to do, systematically chop down this tree until we conquer that goal. So let me know your questions, send them in. I'll do more videos like this. I think it'll help. I think it adds value. If you haven't already, please take a minute, subscribe to the channel. My goal for this channel is to help you build the tools you need to succeed in private practice, help you understand Medicare regulation a little bit better, and help you gain access to the resources you need to answer the questions. Because that's all it is just finding the resource to answer the question. And of course, asking the right questions. Guys, thank you so much for watching. I'll catch you in the next video. Have a great day.